You're watching I Am Not a Pot Plant, Best Practice Supervision of Medical Students in General Practice. Produced by GP Supervision Australia and presented by Dr. Simon Morgan and Olivia Putland. We would like to begin by acknowledging the traditional custodians of the land on which this recording was produced and pay our respects to their elders, past, present, future, and their families.
As a medical educator with GPSA, I'm very, very excited to be co-facilitating this because it's really our first formal foray into medical student supervision. I'm aware that many of our supervisors supervise learners from across the pipeline, medical students, pre-vocational doctors, registrars. But yeah, we're really specifically talking about medical student supervision. And I'm kind of hoping that Olivia's very catchy title was one of the reasons that you've come along, because I think that's just fabulous. I think it's probably the best title we've had this year, Olivia. So there you go.
Oh, thank you. I'll take that.
Simon Morgan, I am a GP medical educator, a GP supervisor of registrars and medical students, and I work at the Aboriginal Medical Service here in Newcastle on a Wabakal country. But I'm particularly excited and happy to welcome Olivia Putland along today, my co-facilitator, who, again, I'm not sure how frequently this has been the case, but Olivia is a fifth-year medical student from Monash University. Olivia, lovely to have you along. What's your 30-second potted bio?
Oh, thank you, Simon, for having me here. Well, the most exciting thing at the moment is that I have 2 days left of my medical degree. I'm originally from Mildura and I've grown up in regional Victoria, and I'm currently finishing my degree at Monash Uni.
Olivia is going on a wonderful holiday in 2 days' time to Southern Africa. But we shall get started because tonight we're talking about medical student supervision, and really these learning objectives we take very seriously when we write them because we do aspire to meeting those. But if you want to boil these down to something a bit more practical, it's how you guys can be better, more effective medical student GP supervisors, make it more efficient and effective for you as a supervisor, but particularly, and that's why I think Olivia's presence is so valuable, to make it really valuable for the student. So I'm going to start really just with a very quick overview of GPSA and how we view supervision. Broadly speaking, I guess, but certainly also for medical student supervisors. We regard supervision as having a few broad elements, including clinical and educational supervision. So your role as a supervisor of any medical learner really primarily is around patient safety, clinical oversight, monitoring the quality of care and making sure your patients are safe. That probably refers more to registrars and pre-vocational doctors who have a bit more independence and autonomy, of course, but it does apply absolutely to students. And there's those 4 out of 5 doctor commercials, I'm the 5th doctor. That's the person, student or otherwise, that you want to make sure isn't in the room with your patients and really needs some oversight. And I guess secondly, it's the educational guidance, that you are facilitating that registrars, that pre-vocational learner and that medical students learning by identifying learning needs, teaching effectively. And one of my favourite cartoons are Calvin and Hobbes. So this is essentially the way to think about it. Clinical supervision is the patient safe. Educational supervision is the learner learning. But if we look at this definition, that again, for those of you who have seen me talk about this before, you may remember a paper now 10 or 12 years ago published by Susan Wern, again referring to, in this case, the resident, but more broadly the registrar. But again, I think this pertains to all medical learners. It's not just clinical and educational, it's the personal development as well. So it very much is, how is that student going? What is, how they're coping, how they're managing, what's their personal circumstances? And again, seeing supervisors tonight from rural and regional and remote locations, of course, that is likely meaning that they have located to that community and there's a real risk of them, feeling isolated. So that's very much part of your role. And you will know of this terminology around the pipeline. I pinched this from one of Olivia's slides, so I'm hoping her references are correct, and you won't remember the figure of 8,600, but it's a bloody lot. essentially we are in strife in terms of the number of GPs and rural generalists in Australia over the next couple of decades in terms of numbers. The RACGP, and I'm sure ACRM similarly, would deem the current numbers of trainees through that pipeline are insufficient to meet workforce needs. And so we talk about leaky because, of course, people drop out of the system and do other things. And it's narrow. It's not sufficiently high throughput to meet our needs. And in some data that we collected this year, 2025, looking at intention to continue supervising for medical students, you see there, so this is very recent, this is from March this year, about a third of supervisors of medical students said they would continue for the next 5 years. Great. But about a quarter said they'll be stopping within the next 5 years. And you can see other numbers really not intending to supervise in the future and unsure. So we are facing a real potential crisis in our existing supervisor workforce and the need to have good, effective supervision, hence sessions like this. And a little bit of further background, and just to kind of give you that sense of what the context is, you may have seen this quite recent headline in News GP from the RACGP. This was a study of final year medical students at the end of 2024 asking their intentions around career choice. And about 15% of them said, I want to be a GP or an RG. And they aligned their personal values as the top reason. That's why I want to do general practice. But their medical school experience was quite a low way down in terms of, why they might want to do it. And this paper from 10 years ago now, so admittedly predates this current bit of work, is pretty sobering. And I'm not sure, and Olivia may speak to this too, I'm not sure that it's changed a whole lot. That in this paper, there were some positives. Medical students like the notion of general practice being flexible, that they can pursue continuity of care, that there's a good work-life balance generally, but they saw it as boring. I mean, I'm kind of hoping that you react to that. Boring, poorly paid, which is not something I'm going to challenge, and of low prestige. So they really did think a career in general practice was not something they would be rushing to. Having said that, and this is very topical now because this came from News GP yesterday, about a third of graduates actually end up in general practice. So about double the number that intend to as they exit medical school for, I'm sure, a whole range of reasons. And lastly, before I hand over to Olivia, perhaps a slightly provocative slide, Olivia. I think you said you saw this and you saw some communication around this today, but I'd just invite you maybe to look down this list, see where your own university may sit, and certainly the one that you're taking students from. And, you didn't hear it from me, but if you want to advocate around how well they're going, that's where they sit. And certainly my old University of Sydney, is pretty low down that list. Olivia, what did you see around this today?
Yeah, I saw it on AusDoc, but it was probably on News GP as well, asking people what their experience was about their universities, essentially how they portrayed GP as a specialty. And yeah, was it encouraged, and also asked for some anecdotes so people could go and fill out that survey if they were interested.
Clearly, I think universities like James Cook have been set up almost primarily for a rural generalist type model, and you can see that there. But it doesn't mean the more established universities down the bottom shouldn't be aspiring to really equipping students to come out wanting a career in general practice and pursuing that. But in happier news, and I'm about to hand over to Olivia, we do know that students coming to a practice and they have a really positive experience are more likely to pursue general practice careers, particularly if they're doing longer term placements. And those who have that rich learning experience of seeing patients and having greater responsibility and accountability increases motivation. But what can help facilitate that good experience? And this is where I'm so excited to be able to hand over to Olivia, who did some work on this as part of her training, and she's about to present that to you. Thanks, Olivia.
Perfect. Thank you, Simon. And yes, like you said, as a part of my medical degree, we undertake a 6-week scholarly intensive placement. And I was lucky enough to complete that with GPSA. And I worked with Rebecca and Sammy with data from GPSA's annual national survey. And my research is entitled I Am Not a Pot Plant, Identifying Enablers of High Quality GP Placements. And it was looking at moving medical students and everyone in the GP training pipeline away from that pot plant, that person that sits in the corner and just observes, and how do we get them involved and enable a high quality GP placement. So, Simon has brilliantly set the scene of how important medical students are in filling the predicted GP shortage and how important high quality placements are for medical students as well. And we also know from previous research that there's challenges for supervising medical learners at all levels. That includes things like remuneration issues, limited time, reduced productivity, and the cognitive load that GP supervisors take on when they also are supervising medical learners. And despite this, there's limited research that actually identifies what are the resources and enablers to overcome these challenges and allow for that high quality placement. So, my research was to identify resource and educational enablers of high quality placement experiences in GP across the whole GP training pipeline. But tonight I'll just be speaking more to the medical student factors that were identified. And so, it's a bit of a background on how we did this. I used qualitative data that was collected from last year's GPSA national survey. And that's a survey that's based on a contemporary understanding of the issues that are facing our GP workforce. And it was distributed online, so some people may have taken part in that survey. Respondents were asked lots of different questions, but the one that was relevant to my research is that one that's bolded there. So it's what resource and education would help you to offer a high quality placement experience. And supervisors, all members of the supervision team, were given the opportunity to answer in 3 separate boxes. So they could choose whether they wanted to answer for all learner cohorts or not. And then moving on from that, I then took this data and did a thematic analysis. And I reviewed and coded and categorized that data. And we didn't come in with any preset themes. We just waited to see what the data told us of what are the resources and education that supervisors need. And then we also analysed all of these the themes based on different categories. So we looked to see if the role in the supervision team, whether it was practice managers or GP supervisors, as well as rural or metro or junior or senior supervisors, had differing opinions on what was important and what was what enabled these high quality placements. So we had 272 respondents in that medical school category. And there were 6 different resource and educational enablers that we were able to identify in our data. So this ranged from teaching resources as the most common enabler, and that was 24% of respondents identified that. And then that was through to infrastructure, which 3% of the respondents also identified. So I'll give you a little bit more information on each of these things, and I'll discuss with some examples. So the most commonly identified enabler for our high quality placements was teaching resources. And this category, it has 2 sub-themes. So the first one on the left was accessing existing resources. So these are ones that I'm sure we're all very familiar with, things like ETG and UpToDate. And some people noted that cost was a barrier to accessing these for students. But that would be interesting to see if all students do have access. Often university portals do enable us to have access to things like ETG. The other part of this teaching resources was access to new teaching resources. Supervisors were asking for lesson plans or practice cases that they could run through with their students. So that was our top enabler, teaching resources. And then our second most common one was university factors. So this theme was a very close second at 23%, and it spoke to supervisors wanting more clarity from universities about what was the student's curriculum, and just some more communication in general of when do placements start and stop, what days are students going to be on placement or not. And supervisors also identified that they were unsure who was to provide the orientation. Could they collaborate with universities to ensure that students knew how is seeing a patient in GP different to seeing a patient on the ward? So that was our second most common one, university factors. And our third one is one that we've already mentioned a little bit, the financial resources. This came up in 18% of responses, and it often related to a general need for increased remuneration. And a lot of supervisors noted that they earned less if they were supervising than if they saw their own patients. And some supervisors also mentioned that they needed to be reimbursed appropriately for hosting learners in order to keep doing it. And then our next one that we moved on to was supervision factors. That was our fourth most common one. And this, again, was a theme that had two sub-themes. So our first one was simply needing more supervision staff. And then our second was having more highly trained supervisors. So having more and the training to allow for highly trained supervisors. So in terms of the having more supervisors, that was having more doctors that were willing to teach to prevent burnout and being able to share the load so that students could also learn from different supervisors within the same practice. And then the training part of having these highly trained supervisors was supervisors asking for things like formal teaching or supervisor modules or webinars. So that was the fourth most common enabler that we identified in our data.
Just to say that's my highlighting, really, because that's what we're doing. I'd love to be able to increase the remuneration for what our hardworking GPs do, and we'll get onto infrastructure and build a few extra consultation rooms. But what we can do, hopefully, is to do some training. So that's the nub of this, certainly.
Yeah, absolutely. Thank you, Simon. And another thing that unfortunately we can't just magic up is time. And that was our fifth most common enabler. And that was where members of supervision team identified that if they spent more time with the learner had a better quality experience. That one-on-one time where you can provide feedback to the learner, it really is invaluable. And a lot of supervisors highlighted that they needed financial resources to protect their teaching time because they have many different time constraints within the day. And then our last factor is infrastructure. This was actually the least identified enabler, and there was only 3% of respondents in the medical student part of this survey. But everyone that didn't mention infrastructure noted that having a room for students to see their own patients and be able to parallel consult is invaluable because that's where they get that hands-on experience and they can stop being that pot plant in the corner and actually have the opportunity to see their own patients. And so these were our factors that we had across the board. Then I did a bit of a further dive into these results and analysed the data to see if there was a different order of themes or different types of themes when we looked at respondent characteristics. And the first one that I looked at was rural versus metro. And we found that university factors was a more common enabler when we looked at rural sites, whereas metropolitan respondents noted that financial resources was their most common enabler. And then we decided to look at length of time supervising, so our junior supervisors versus senior, and the split here was 5 versus 6 years. And so our junior supervisors, those with 5 or fewer years teaching experience, identified that they needed more support from the university, the things like orientation, up-to-date curriculum guides, as well as teaching resources, those new and existing teaching resources, in order to have facilitate high quality placements. And then you compare that to our senior supervisors, those who maybe already know the university framework and already have their teaching resources sorted. They recognise that time and financial resources was what they actually needed to enable high quality placement. So a bit of a difference there. And then the last thing that we looked at was practice managers versus GP supervisors. And practice managers were the ones that consistently cited that university factors were the top enabler. There are people that are often emailing the universities and speaking with them directly, and they were the ones that identified this as something that would enable them to facilitate more high quality placements. And then in contrast to that, the GP supervisors, as a member of the team, they recognised teaching resources as the most prevalent enabler there. And so from all of this data, we came up with some recommendations. And so to start with ones relevant to sort of GP practices, universities, and some other organisations, was that universities should enhance curriculum and exam resources. So what this might look like is clear, user-friendly curriculum outcome documents that GPs can target exactly what's on the curriculum and how they're going to teach it. It's also important that these are shared early with the supervision team so that GPs can ensure that they are teaching the curriculum and can plan the curriculum out. The next one that we had was improvement with communication channels. Universities should look to improve their communication with GP practices, especially with practice managers, because they were the ones that highlighted this most often. Then universities can ensure that they prepare their students as best as they can for their placement. So they could provide them with an understanding of how a GP placement is different from hospital placement, because at this stage, that's all that students would have done. And they can also work with GP supervisors to ensure that students are orientated to their new clinic. So this might look like making sure there's a checklist that students know how to use all the computer systems and that they know all the referral pathways and who they can ask for help, like if they need help with vitals, where they can go to get the nursing staff to assist in that whole GP supervision team. Furthermore, policymakers should improve support for and the quality of supervisor education. So this could look like funding to attend short courses or webinars that can provide skills and information on teaching and supervision. And that would be particularly important for our junior supervisors who identified this most often as an enabler. And so we thought of these recommendations, and then we also thought of, well, what are some policy agendas that could come out of this research? So first one was related to funding, to accessing additional educational resources, things like ETG and up-to-date. But like I've already mentioned, it would be important to look at how many students actually have access to this through their university portals to save a double up of funding. Also, we can look at increasing the size of the GP supervision team. And we know that we have to target this at multiple levels, so increasing the attractiveness of GP supervision, as well as ensuring that we support our junior supervisors and retain our senior supervisors as well. And then another policy agenda that we came up with was strengthening the funding for GP supervision, particularly funding to protect teaching time, because we know that that is invaluable for the students to have a high quality experience. And then we could also look at providing targeted infrastructure assistance, especially to those practices who need those extra rooms to facilitate parallel consulting. And then once we thought of these policy agendas and recommendations, we thought, where to next? Where can we guide some future research? So we thought it would be interesting to look at medical learners' perspectives. So this data was just looking at the GP supervision team. So also looking at medical learners, so then we can better place policymakers to make more impactful change for multiple stakeholders. And then we also thought we can look at how are people using the resources that we already have. We know that GPSA has a learning and teaching toolbox. However, we could look at how that's being used to identify what are the gaps and how can we provide targeted resources to fill that gap. And then given financial resources was raised as an enabler quite often, we could look at the cost benefit analysis of supervision in the GP space, and especially look at why senior supervision team members raised financial factors as a bigger enabler more often than junior supervisors. And given that our senior supervisors play a really important role in retention and mentoring, as well as sustainability of the workforce, seeing if we could get a better understanding of that to provide more targeted financial resources in the long term. And then, so just as a bit of a summary overall of my research, we know that high quality GP placements are really important in addressing our predicted GP or RG shortage in Australia. And our study was able to identify some key enablers that could enhance the quality of placement. But we need support from general practices, training organisations, as well as government bodies and policymakers to see the practical application of these resource and educational enablers that we were able to highlight in our study. That brings us to the end of my research.
Olivia, I was so impressed when I saw you present this some months ago and immediately thought we really need you to present this to our members because it's such a rich area of food for thought and thinking and advocacy. I mean, there's many things you've talked about that our members and indeed ourselves can't, as you say, magic up or change overnight, but we can advocate. And it's really great to see somebody in your level of training taking this on. The question that hasn't been asked is, and maybe I should have asked it at the end, but what are you going to do when you, after you finish your hospital years, Olivia? How inspired are you about general practice?
Yes, I definitely want to do RG, and I've actually taken an RG internship. So I'll be starting my medical career in Echuca, which I'm very excited about.
And that wasn't a Dorothy Dix. I didn't know that when Olivia presented. She may have been a budding orthopaedic surgeon, although she may not have chosen this topic, of course. But yeah, I'm thrilled. That's great. You're going to be a very, very welcome contribution to rural Australia, I'm sure. I really thought that was such a great way to kind of set the scene and get people thinking about some of the issues to make for a really high quality general practice placement. Because, forgive my indulgence, but I will, for 30 seconds at least, describe the experience of my son, who is now a PGY2 up in Darwin, but had two absolutely contrasting general practice placement experiences. One where it was worse than being a pot plant. I think he was possibly a broom in the broom cupboard. It was significantly worse than just sitting in the corner. And in fact, it was a pretty horrible placement, such that he complained and was moved appropriately. From there, where he really did think he felt very soured about general practice, to a place where he worked with a GP who was absolutely excellent, admittedly in the middle of the city, but so he had a narrower scope of practice than maybe some of our doctors on tonight. But he absolutely was inspired by the breadth, the continuity, the comprehensiveness, the quality of care, and left that placement probably no closer to saying I want to be a GP, because I don't think he will be, but certainly having a much better appreciation of where general practice sits in the health system and what GPs do as in their day-to-day work. And that's as much as anything. If we do have students with us who we know are going to be pathologists, it's still okay, I think, to invest into them, maybe not quite as much, but to say, it's so important, what we do, and to make that experience rich. I imagine you'd agree, Olivia. Is that a sort of not just reflecting on the work you've done, but your experiences in your placements?
Yeah, I would definitely agree with that, Simon. I think the more, hands-on and the more valued that you feel as a student, the better experience that you do have.
So in terms of resources, we are endeavouring to develop some resources and try to make those sort of available through the parent universities. And they're really based, they're sort of the main, we've got a lot of resources, as Olivia's referred to, and I know I see some names that I'm very familiar with and people know, of lots of the resources that we have available on the GPSA website, including a consultation skills toolkit, including the teaching and learning toolkit, which I'll mention at the end. But we are developing a new resource that's really based on these so-called tasks or responsibilities or core roles of the medical student GP supervisor. But for the sake of this guide, we've kind of divided it into these big ticket kind of broad headings. And I'm going to, over the next 20 minutes before we finish, sort of try to unpack these a little bit. by way of introducing you to the way we're trying to think about it when we release this new medical student guide. So I won't go through those now because I'll go through them in turn. But for us, they're the really core aspects of practical supervision. The first one, of course, is facilitating, fostering, developing, nurturing, whatever word you like, a rich, sort of mutually supportive learning environment. And that's not just for that one student who's there maybe for 6 weeks, but it's for all the staff. So when the student arrives, they get a sense of, wow, this place is a learning culture. And again, with no time to talk about this in any depth, but many of you may know of our GPCLE framework and tool, the General Practice Clinical Learning Environment tool. It's research-based. It's something that internationally has quite a bit of carriage now. And so if you're not familiar with it, you can use that as a sort of quality assurance or quality improvement type mechanism in the practice. And sort of modelling lifelong learning, making feedback, just that everyday regular aspect of the way you work with your team, including with the student. I'm just going to go through these reasonably swiftly. The second one is really sort of preparation for the placement. Really interesting, Olivia, you talked about the need for good communication with the universities and also how the practice managers, that's very much their domain, making it a whole of supervision team, process, having a checklist to make sure things are covered, and your own practice manual, thinking about expectations, getting to know the student and the importance of knowing who they are, what their background is, what they might be able to contribute, so important. And I think something that may be often neglected is just that sense of the community and what sort of place they're coming to, particularly if they're out of their usual area. And in saying that, not just the geography and maybe the history, but certainly the cultural heritage of that place, including the Aboriginal and Torres Strait Islander people. And it is a nice thing, I think, to acknowledge country where it's appropriate, or indeed, if you are a First Nations person, talk about that more authentically.
Understanding the curriculum and intent of the placement is very important, and that's coming under those expectations there.
But I think when you say curriculum, I'm sure lots of GP supervisors' eyes would glaze over and think, oh my God, do I have to read a curriculum? That's a very fair concern. But just to get a sense of what they need to get out of this, what's the student trying to take away from a placement, both what their own personal needs are and what the university's hoping that may come. And that's this notion of expectations, I think.
Yeah, and I know, for example, in my placement, our supervisors, they didn't always refer to our curriculum documents, but they were very good at asking us what we were missing out on. And if there was an expectation that at the end of our lecture days, they would say, what would you like us to cover next week or in the next coming weeks? So even if curriculum documents perhaps aren't your thing, there are other ways around it by really making sure that you engage students and ask them what they need.
Yeah. Now, I came across this very recently, and apologies to ACRM GPs, ACRM supervisors, if there's an equivalent, because I am not aware of it, but it may exist. But certainly I came across this very recently. This is an RACGP resource, and it's actually very good. And it's something maybe along the lines you were referring to, Olivia, some kind of pre-placement orientation processes that a student can do. Now, I think it's pretty available for students to be able to do. You can see the modules here: Introduction to General Practice, the Consult, Clinical Reasoning, Preventative Health, Common GP Consultations. There's a few videos. There's some sort of reflective activities. It's actually a very good resource. And if a student, I think, hasn't done something of this nature, I think encouraging them to do something like this early on in the placement would be, or through the placement indeed, would be really valuable. So, yeah, I was quite surprised actually to see this and to realise that it exists. I will come back to that because there's another couple of points to refer to. So the third big element is sort of monitoring and maintaining patient safety. Again, obviously with students who are not independent practitioners, there's much, much closer clinical oversight, but it still is so important to get a sense that the patient is safe. I think when we talk about safety, we think about clinical safety, but we also must think about cultural safety and having a sense that the student is culturally safe with our First Nations and patients from other cultural backgrounds. And the availability, all those A's, accessibility, availability, approachability, all those sorts of things make safety so much more important. I'm imagining you're sitting there, yes, of course, they're a student, I have to do those things. But I think, sometimes there are pressures, sometimes there are circumstances that make those less rigidly adhered to. So, yeah, I think it's worth reminding. The fourth big ticket item, of course, is teaching and learning. And I've divided this into two because I think it's nice to think about the what's to teach and the how to teach. And again, we've talked about the importance of identifying learning needs. Now, students are probably much less, I think, in many respects, able to do this perhaps than a GP registrar who's sort of in that general practice focus and thinking about exams and the patients they're seeing. Students have come from a hospital environment where they are very much exposed to the breadth of clinical medicine and may have less skill in being able to define those things, but it's still really important. I came across a paper recently which I loved. It was called Sailing the Seven Seas. There you go, Olivia. It's only marginally less engaging than I'm Not a Pot Plant, but I really liked it. Sailing the Seven Seas with a capital C. And these were the 7 C's of what constitutes general practice. What is general practice? It's 7 C's. But they include, there you go, first, contact. So the first, we see patients unreferred, continuity, comprehensiveness, coordinated care, community engagement, patient-centeredness, and complexity, but compassion and communication are also important. But there are a couple of other C's, and I think, Olivia, you may have mentioned these when you had a look at the guide for us. And these are the 2 C's that I think, if you forget everything about what you are teaching your student, these are the 2 things that I reckon you can focus on. And that's how to run a consultation, how to drive the car, which is, literally how to get in the driver's seat, turn the thing on and navigate through the consultation, going past the appropriate checkpoints, being safe, coming out the other side. A, and B, I mean, you're not going to do it in a 6-week placement, but at least starting to support the student to reason soundly, so clinical reasoning. And I think you made that observation, Olivia, when you had a look at the draft guide, saying how much those elements of your time you enjoyed the teaching on, and how much you would have liked even more focus on that. That's your observation?
Definitely. I mean, I had actually never seen a patient by myself in my 3rd year, so I had no consulting skills, and yet I was still someone that went to placement and met all the requirements of 3rd year. But it wasn't until I entered my 4th year and when I did my GP placement that I actually learnt to have consulting skills. So I really relied on my RGs to teach me what they were. And similarly with clinical reasoning, I think was important we had all these resources, but I didn't necessarily know how to use them until I did a GP placement. So the GP is actually showing us, okay, well, you've got ETG, but this is actually what you do with it, and this is how you find drug doses.
Yeah.
And if you're not sure about what to do, this is which, guideline you can look up. Those sorts of consultation and clinical reasoning skills are invaluable, and we don't have them until we've done this GP rotation.
Oh, that's actually very inspiring. So thank you. What to teach. So, what's this thing on this patient's ear? Great. We can talk about SCCs and what to do about them. But those soft skills, which I went to a talk recently and they said, I hate the word soft skills, let's call them power skills. But things like professionalism and team management and leadership and those sorts of things, we can help instill some of those skills in our medical students. So, in terms of the what to teach, I just wanted to go back to that RSEGP resource. You don't have to encourage students to use it, but some of those questions around what would you like to get out of your term? How do you think you can maximise your experience? What would you like to learn? As we know, and somebody put in the importance of feedback, it's so much better to get a self-assessment from any learner before we suggest what they might learn or what they might do differently. So in some mechanism to say, write it down or let me know what you'd like to get out of this placement. What would you like to learn before, and that's where the curriculum obviously can support. And just again, a reminder, so it talks about consultation skills, it talks about clinical reasoning skills. It's a very rich resource. And I won't talk about this, but this is a GPSA approach to learning, and it just talks about those 4 R's. And another way of thinking about, you've got your student and you may wish to think about how they interact with the patient, so rapport and the relationship, how they interact with the problem in terms of the way they reason, how they interact with the system, in terms of all the organisational stuff. Probably less so for a student, to be honest, all the billing and Medicare and PBS and things, but there's some important elements there. And really important, I think, how they interact with themselves. The 4th R, reflection, how they can start to be, if not already, a truly reflective learner. So about, I think, 3.5, because this is the other half of teaching and learning, and that's the how to teach. And I know when we talk to supervisors and registrars, there's a smorgasbord of potential teaching modalities. It is narrow, I think, in medical student teaching, fair enough to say. Obviously, a lot of direct observation and reverse direct observation, watching students work and students sitting in, notes review and those sorts of things are less important. We do talk about parallel consulting, which I won't talk about in any significant depth. There was a great tip that was made to me about if you have more than one student, that working together is really effective as a parallel consulting team, where one may take notes, say, or it's just done jointly. But some tips there around trying to ensure a broad clinical exposure, lots of open-ended questions involving a wide range of staff. And I shouldn't have put it last, but I did, but making learning fun and really trying to enjoy your teaching, and that's one way of really engaging a student. And for those of you who have come across our consultation game, which we developed last year, that type of sort of gamified learning, quizzes and activities and role play, little snippets of role plays and things can be really rich and make learning really fun. If you're interested in getting that, we are talking to the universities about them accessing it for you, but obviously you can get that, and you can get that on our website if you're interested. And we have lots of resources. Olivia talked a lot about resources. Now, these aren't clinical resources or guidelines like ETG or AMH, but they are teaching plans that students can do independently, or certainly, if you're doing a bit of a teaching session around diabetes or a consultation skill, or how to do a 715 health check on an Aboriginal and Torres Strait Islander patient, you can use these. These are all available on our website too. Feedback, and obviously it's as critical for the medical student as it is for any learner in the practice. Inviting self-reflection from the learner, regular feedback, asking the learner, the student, to give you feedback as a supervisor, incorporating that as part of the culture of the practice, thinking about feedback on not simply the consultation, but on non-clinical skills. All those elements makes for a really rich learning environment. Supporting wellbeing, we've touched on. Obviously, one would hope students don't come a cropper, but we know they do, as other learners do. So identifying a student in distress or difficulty early, particularly where they might be relocating or there's external pressures. But certainly for all students, making sure they know you've got their back, that you're supporting them, that you're looking after them, that you're available. And just that regular check-in, how are you going? Are you doing all right? We often assume that it's a bit of a easy job, I reckon, as a student, go and have a bit of a yarn, but who knows what types of experiences they're having, asking patients about their lives, how triggering or traumatic that may be. So it is really important, I think, to be attuned to their emotional and other needs. And lastly, number 7 on the list of the kind of core tasks is just around ongoing professional development and reflective practice. And I snipped the title slide of this because that's what you're doing right now, and I'm thrilled that you are here upskilling in this domain. They are the 7 practical tasks of supervision. And lastly, so many of you will know of GPSA and our resources. We've mentioned the couple of toolkits, one on teaching and learning, one on consultation skills, which you're very freely able to Google. We have lots of guides. This is one on practice-based teaching as an example, but there is very soon to be released a guide for medical student supervisors, which we will be distributing hopefully through the universities. We have the teaching plans I've mentioned. We've got lots and lots of supervision and teaching webinars and FAQs, and we've got some how-to teaching resources. So have a look at that. They're all available on our website. I can invite Olivia to make any final comments, any reflections on what's been said. I might see if there's anything to share.
I think my just final comments from a medical student perspective is great placements are ones that we get involved and we, learn from being involved and seeing our own patients. So whatever opportunities there are to, facilitate parallel consulting, or maybe it's things like getting involved in skin excisions or other like RG hospital-based things, students are always very grateful for whatever hands-on opportunities that we can get.
Yeah, and taking students outside the practice was another tip that I was given. So not just to nursing homes or home visits, which I know happen less frequently now, but literally outside the practice. Let's go and have lunch at the, local cafe and have a yarn. Let's go for a walk around the block and talk about what you've seen this morning. Just that sort of engagement, I think, makes for a really rich experience. Olivia, I'd really like to thank you for talking so eloquently about this really important area. Thanks for doing the work. Thanks for doing the research, and thanks for coming along to share it with our supervisors.
Thank you very much, Simon, for giving me the platform to showcase all this research.
Yeah, and lastly, have a wonderful holiday, a very deserved holiday. You have 2 days left of your medical career, so a huge congratulations for that, and happy days. Enjoy your internship next year.
Thank you very much.
Thanks all. We'll see you at an upcoming event. Lovely to have you along. See you soon. Bye-bye.
Thanks for watching. We'd love your feedback. Please comment or subscribe to our YouTube channel for updates on new videos. If you'd like to ask a question or suggest a topic, you can contact us via our website at gpsa.org.au. GP Supervision Australia is supported by funding from the Australian Government under the Australian General Practice Training Program.